Welcome to the Clear Impact Webinar Series 2024, where we'll be joined in conversation by NHS clinicians, system leaders, commissioners and colleagues from the National Clear Programme team to discuss and share the learning and impact from our recent Clear transformation projects. Our Clear transformation projects have been supporting the NHS tackle a whole range of national priorities, including proactive care, urgent and emergency care, elective recovery, mental health, ophthalmology and primary care. Today's webinar centres on the Clear Living Well 2003 project, a transformation project that supported 3 primary care networks in Cheshire and Merseyside to design new models of care for the prevention of cardiovascular disease. The project was commissioned by NHS England and aligned to key ambitions in the NHS Long Term Plan and the National CVD programme. Okay, so I'm delighted to be joined today by Dr. Gemma Askey, who's a GP within the East Warrington PCN, Emily Benbow, a care coordinator representing the Central and West Warrington PCN, Scott Morgans, the Health Creations Manager at 1 Wirral CIC in Healthier South Wirral PCN, and my colleagues Nat Scott, Clinical Consultant on the National Clear Programme, and Claire Perkis, our project sponsor on the National Clear Programme. Claire will be introducing you to the National Clear Programme shortly before we explore the Living Well 2023 programme in a lot more detail. So let's have a quick look at our agenda for the day, please. Okay, so once Claire has shared her overview of the National Clear Programme, Nat will then talk us through the Clear Living Well 2023 programme in more detail before our guest speakers talk us through the key findings, recommendations and projected impacts at their sites. Nat will then lead a personal reflections segment in conversation with Gemma, Emily and Scott. We'll then conduct our Q&A segment at the very end, where you'll be asked to put your questions either in the chat or put up your hand emoji, and I'll be able to, I hope that we'll be able to get to all your questions during what we hope will be maybe 10-15 minutes of Qs and As. For the time being, if I could ask you to all have your microphones on mute, and I'll hand over to Claire to start the show. Thank you.
Lovely, thanks very much, John. If we could skip on to the next slide, that would be great. So, like I said, I'm here just to give an overview of the work that we do here at Clear. So, the National Clear Programme as a whole was originally developed in partnership with Health Education England and is now sponsored by NHS England, regions and systems. We very much believe in putting clinicians at the heart of care. So working alongside organisations, putting the people that are seeing patients in the driving seat, enabling them to lead transformation work by enabling access to data, so local data, and sort of tools and support really to go out and speak to people across the system to really kind of get down to what the challenges in the system are. And from that, create innovation and new models of care using our tools and workforce redesign to come up with some really well thought out, locally based solutions to the challenges that they've heard about. We move on to the next slide. Thank you. So how do we do this? So Clear has an approach that spans across 4 different phases. So we have clinical engagement, data interrogation, innovation, and a recommendations phase at the end. So what do all of those look like? So during the clinical engagement phase, clinicians will go out and speak to a wide and diverse range of stakeholders across the system to really hear the views of those that are kind of treating the cohort of interest. So finding out what works well, but maybe what else is a challenge or what people think could be improved. They'll then go ahead and look at the data, so the quantitative data that's been extracted again from the local systems. And again, there'll be some key questions that have come out of clinical engagement that will be looked at. So again, what experience of care are the patient group of interest having? What's the wait time like? Are they using services more or less than other groups? And what's the impact of that on clinicians and people that are providing the care? So those 2 things are then brought together and triangulated to really come up with a really in-depth understanding of what those challenges are. And those are then taken into the third phase, which is innovation. And this is the chance to kind of go wild, think differently, look at, again, sort of less traditional and less maybe medically led models of care, and really come up with some solutions that are going to have a high impact and address those challenges that have come to light in the clinical engagement and data interrogation phase. And part of that as well, we'll be looking at workforce redesign, coming up with a costed model of care, and again, some impacts. So again, if we do this, what does that look like? So what does it look like for patients? What does it look like for staff? And what does it look like, again, for processes and the system? Finally, in the fourth phase, all of that is brought together into recommendations. So a nice, clear report that outlines that narrative of how the solutions have been landed upon. And again, a high-level implementation plan. So what would that look like if you wanted to take that forward and actually go ahead and start implementing those solutions? If we go on to the next slide, please. So I'll skim over this one. And again, this is just a kind of high level overview really of the aims of the CLEAR programme. And our team now comprises 70 staff, and we're made up of a mix of people from different backgrounds. So lots of people we have working with us are NHS clinicians, but we have people from education backgrounds, data analysts, communications, marketing, all sorts of people, but all working together towards that same goal, which is really trying to improve patient care and make things better for those that are using services. If we move to the next slide, please. So you can see from the map, we've got had quite a diverse portfolio of projects around the United Kingdom. So I'm not going to read them all out, but again, we've not just done work in primary care, we've done work in urgent emergency care, mental health and ophthalmology as well as others. And we've completed 50 plus projects now, with more underway currently. And it's really exciting to kind of see where that's taking us. Next slide, please. So the aims overall for us are, as I said at the beginning, a clinically led culture. So we really want to have clinicians controlling the outputs that come out, basically. So the people that are closest to giving that care, really in that driving seat. We want to create capability. So again, hopefully giving people new skills that can be transferred to other quality improvement work or transformation work. And again, hopefully people being able to share those skills with other members of their team for future work that happens in the healthcare setting. New ways of working. So obviously, again, the end point of all of our projects is to hopefully come up with some solutions and some different ways of working that address some of those challenges that have come out. And again, coming back to that clinical ownership. So those solutions being clinically owned is really, really important, because again, if it's owned by the people that are delivering the care, we hope that actually that's going to result in much more tangible and lasting improvements, because the people that are having to implement them have been involved from the beginning and really believe in the solutions and the transformation that they're proposing. Next slide, please. And again, this is the last bit from me before I think I'll hand over to Nat. So this is a high-level overview of the 26-week CLEAR programme. So you can again see the different colours split into those 4 different phases. And I won't talk in detail to this, but again, it's a very kind of well thought out, in-depth programme that really, again, hopes to equip people with the skills to take this work forward for future projects. So I will pass over now to Nat, who's going to give an overview of the Living Well programme.
Thanks, Claire. If we go to the next slide, please. So where did Living Well come from? So CVD is cardiovascular disease, which affects around 7 million people in the UK. And we know it's a significant cause of disability and death. It affects those who are the most deprived. So the most 10% of the population are almost twice as likely to die from cardiovascular disease than those in the least deprived. The long-term plan has set out to tackle CVD as a priority, and it's considered the single biggest condition where lives can be saved over the next 10 years. So where Living Well came from was the clinical policy unit of NHSE, the CVD prevention team, commissioned CLEAR to complete Living Well with 3 PCN sites and 1 proof of concept site. And we were lucky enough to work with East Warrington, Healthier South Wirral and Central and West Warrington. And by a stroke of good fortune, they all sit within the same ICB. So I think one of the biggest successes, and prove me wrong later, guys, is that of the networking that the project has kind of led to, in terms of, because you're all neighbours, so it's actually been really good to be able to work together in that way. If we just move on to the next slide. So just a little bit of background in terms of the timelines of Living Well. So actually it started in 2022, all the project setup and planning, and you can see that actually quite a lot of planning goes into it. Within that planning phase was also the pilot project, the proof of concept project that we did with another PCN. And then we went live with our 3 sites, I believe it was end of March, and we started our clinical engagement phase, moved on to data in May and June, onto our innovations towards the end of July and August, followed by the recommendations and the project closure towards the end of November. Next slide, please. So what does that look like in terms of numbers? So we have the 4 sites that we've worked with, and that comes to 19 GP practices between the 4 PCNs. There was 89 individual stakeholder interviews as part of clinical engagement that was conducted, and some of those interviews, because the sites sit within the same ICS, were conducted together, so that was quite interesting. So that information was shared. There was nearly 230,000 patient records that was looked at through data interrogation, which looks like something like 5.5 million appointments, nearly 20 million consultations. We had 4 face-to-face workshops between London and Liverpool was our choice of destination in the north. And out of that, we have 7 new models of care. Next slide, please. So just very briefly, these are the models of care that have come out of Living Well 1. I'm definitely not going to go into the detail that each one deserves at this point, but the details are within the case studies, which are on the CLEAR website, I believe. So please do refer if you want any more details. Next slide, please. So this is the Living Well Dream Team. This is us up at Liverpool for one of our face-to-face workshops, and I believe we've just done the chocolate sorting exercise, hence the number of chocolates that are on the desk. That wasn't just to get us through, that was actually part of Living Well 1. And then I've just put the LIBA building there as well, just to remind me where I was. Next slide. So what does the models look like in terms of the projected impacts? So with the 4 models, including the proof of concept, it was projected that it would be a cost savings to PCN of nearly 1.6 million. And what does that actually look like? So that's including direct revenue from any changes to any models, and also 11,000 GP appointments and 45,000 consultation activities, which are potentially going to be avoided through the new models of care. And then just to view that in a slightly different way, that is potentially 1,600 GP hours saved per year, and in addition to that, 3,000 primary care hours saved per annum. So in addition to any costed savings, we did look at savings that would potentially affect the wider system, and we felt that there was up to £1 million worth of savings with our models, potentially 62 adverse events saved over a 3-year period, and a £2.5 million societal return on investment. So not too bad in terms of those projected impacts, so well done. Next slide, please. So you'll be pleased that you're going to stop hearing from me and hearing from those that lived and breathed it for 26 weeks. And I think Dr. Gemma Askey is first up.
Hello. Apologies, I've not got a nice formal background. This is the problem of being a clinician. It's in between surgeries, so I am in my room, in my scrub. So I'm Gemma Askey. I'm a GP that works in Warrington, have done for over 10 years now, and I had the pleasure of working with East Warrington PCN on this project. East Warrington does exactly as it says on the tin. It's a PCN to the east of Warrington, approximately about 32,000 patients. And a really interesting mix in terms of deprivation. So huge numbers of patients in the most deprived deciles, and actually a big number of patients in the least deprived deciles. So an absolute mix within our GP surgeries of the patients that we're seeing. Next slide, please. So as you saw, that 26 winding bit, we managed to squeeze this down into 3 main key findings. So the big one, which I'm sure is not surprising, is the health inequalities, which I think we all know about the cost of living crisis that we're facing. But we found that our population is quite a young population, and there was a huge element of health inequality there, and the impact that that cost of living crisis is having on our patients, and therefore their CVD risk. The patients are stealing Calpol became a bit of a theme for us, because it's just quite a emotive, shocking thing to think that actually people are struggling so much financially, they're having to shoplift Calpol to look after their children. We found through all of the data interrogation that there were a lot of opportunities missed for primary prevention. There was a very low uptake of lifestyle referrals, and also quite a low level of personal health responsibility within our patients. These little speech bubbles were sort of direct quotes when we did our clinical engagement, and one patient saying, "I don't want somebody telling me how to manage my health and well-being." And the final thing, which again, probably not surprising, was the limitation of resources. We know that the NHS is at a crisis point, and that workforce being at capacity stretched across all systems, so community pharmacists, the voluntary sector, it was huge really. And one of the GPs said very early on, look, we're at full capacity. When I'm trying to sell how we can improve things for them, the thought of doing any more was just overwhelming for them. Next slide, please. So after all of that, what we came out with was a new model of care, which was an end-to-end pathway. And our aim was to look at hypertension diagnosis, so increasing the number of people diagnosed with hypertension and improving the treatment of those already diagnosed. And as a clinician, I was really keen on the so what. I didn't just want this to be a case finding service. I wanted to make sure that actually if we're detecting hypertension, we're treating it properly, because that's the thing that's going to impact those CVD and actually change the lives of people. What we suggested was creating a practice-based CVD team, and we tried to do that using the existing workforce and upskilling other members of staff. So actually looking at the skill set rather than the job title. We felt that we needed to be a huge focus on motivational interviewing to really get that engagement with our patients, so them to understand the importance of that preventative of lifestyle changes and how key that was in reducing CVD. We also have looked at something which is referred to on there as the in-reach worker, and that's going to be a real collaborative approach with the voluntary sector. So rather than us as clinicians in the NHS going out and trying to attract people in, actually we are hoping that we can get an in-reach worker who's already working with these individuals in the community, promote the message and bring them to us. I'm guessing that's me prattling on too much. I'll move on to the summary of impacts. So we hoped that the new model of care would create a saving of between £173,000 and £247,000 to the PCN. Some of that will be legitimate hard cash and increase in QOF payments, but a lot of that will be about GP appointments and GP time saved. If we can get this skill set done and train up other people to deliver this care, we hope that that will make a big difference. And also longer term, there might be even more savings as people are living healthier lives if they're encouraged to engage in those lifestyle changes. We hope that there will be a lot better outcomes for our patients, that will reduce the incidence of strokes and MIs, and we estimated that would be about £100,000 over about 3 years, as Natalie had already said. And also to really target those health inequalities. We don't just want the worried well turning up for appointments. We actually want to get to those people in those areas of deprivation and really encourage them to engage with us in primary care. And we hope that actually using that in-reach worker, we can slowly increase that up to about 15% within a couple of years. And as I said, the bit that strikes a chord with me is that release of my time as a GP so that I can spend that elsewhere and upskilling all of the workforce around us. Thank you.
Hi everyone, I'm Emily. I am a care coordinator in Central and West Warrington. Part of our project team, we had Dr. Awasemo, myself, Dr. Stevart, Dr. Mount and Natalie, who you just heard from. Again, the name gives it away as to where we're located. We're in the central and the west of Warrington. The central bit of Warrington is very deprived. So again, we have mostly a very deprived population within our PCN. We've got about 56,000 patients across 6 GP practices. So we are quite diverse, quite spread out and a large PCN. Next slide, please. Thank you. So again, from our clinical engagement, which was part of the first six weeks of the study, there were 3 key themes that were coming out, and they were opportunities to improve communication, inefficiencies of our CVD pathways, and opportunities to increase the capability and capacity of our workforce. So really that was just making sure that everybody is working as cohesively as possible. We were finding between GP practices and the practices in the PCN, and also with our third-party providers and community services and the patients, there was just this breakdown of communication at every stage. So we're really working to improve that and streamline all these processes, especially with the pathways. So again, they'll reduce those inefficiencies, which will increase our communication and visibility across the piece, and using our R's workforce to work across the practices. So we're relieving that burden from the GPs and upskilling those so that they can not only work across the PCN, but then take those skills into practice. With the pathway streamlined, they'll be able to work across any of the sites. Next slide, please. Thank you. So why do 1 recommendation when you can do 4? We really like to make life hard for ourselves here. So we came up with 4 new models of care. We're moving forwards with 2 of them, the first and the 4th one. So I'll just run through them all now. The first one is the PCN Health Check Hub, which I'm leading on as part of our Living Well 2 campaign. So it's centralised delivery of NHS health checks and using our enhanced access slots, our PCN estates that we have, which is also dual purpose for our COVID vaccine clinics, and using our R's workforce. Through all of this, streamlining our pathways, improving our efficiencies, we're going to be able to make every contact count for the patients, really get involved and get to the heart of what the patient wants in terms of their goals and how we can help them to reach those. And once we've got all that model up and running, we'll start taking it out into the community. So going to community centres, places of faith, so we can reach people that would not access traditional GP settings and try and reduce those health inequalities by providing the exact same process with the referrals, with the blood test, with everything, but in a place that they trust and building up those relationships. Sorry. I'm going to waffle for a bit longer on this one. Enhancing our pre-diabetes reviews. So using the pre-diabetic annual blood test to have a quick health check and check in with the patients, educate them around the risks of diabetes so they really understand why we need to look at making these changes now while you are pre-diabetic, and trying to not only increase referrals, but really get people to try and reverse pre-diabetes where possible, and just making that appointment time count. And then the recall of a BMI over 30, that's another project that we're working on. My colleague Becky is running this one. We are going to have a proactive offer where we go and offer people with a BMI over 30 every other year NHS Health Check style appointments, where again we can offer weight management, other relevant referral services, patient education and patient-centred goal setting. Next one, please. So our impact, if we run all 4 models of care, which in time we hope to, it'll cost around £77,000 to run these, but the costs will be offset through reduced consultations and increasing revenue through QAF and DES. So the overall return to the PCN should be between 650,000 and £1.25 million. We really hope to target better patient outcomes because we're going to have reduced instances of stroke and MI, up to 24 cases over 3 years, which equates to a system saving of about £270,000. And with disease avoidance, because we're proactively managing these things, we'll release around 30,000 primary care consultations, prevent up to 463 A&E attendances and reduce medication utilisation, with a societal return on investment of £180,000 roundabout. And overarching all of this is our patient satisfaction. We want to make sure that our patients really understand why we're doing this. They feel like they're getting better care, reducing those health inequalities within our population and being able to proactively manage their health. And then whilst we're doing that, we are building our capacity within the workforce, upskilling people so that not only can they do this project, but they can run into their practices and promote their health there. Thank you.
Hello everyone, I'm Scott Morgans. I'm the Health Creations Manager at One Wirral CIC and one of the CLEAR associates that supported the Living Well project in collaboration with Healthier South Wirral. So just to give you a brief snapshot of the PCN comprises of around about 50,000 patients across 6 practices, and we have a large working age population. The kind of scope for this project was to kind of look at enhancing and complementing some of the work the PCN have already undertaken centred around CVD. Next slide, please. So here's a brief summary of the key findings we identified in the early stages of the project. Some of these being capacity issues with an increase in workload identified within the PCN and a general trend and upwards trend in appointments and consultations, but also other areas such as estates and being able to house a growing workforce, particularly around recruitment of the RS roles. Variability in processes across the different practices that make up the PCN, particularly in the case of CBD, which differed due to a range of different reasons, due to the kind of staff that they had available to them, or even potentially the practice population size. Training and development of the workforce, again, with a focus around cardiovascular disease. Comments included being able to just access consistent CPD across the different roles within the PCN. And ensuring there was a level of consistency in understanding of CVD as well that would naturally translate into patients as well. Access, particularly looking at other ways to access support. So our goal was to always look at how we can enhance those sort of touch points, enhance options and choice for patients, and improving the ways we could reach the local community we serve. Next slide. From our key findings, we created a new model of care that focused on CVD prevention, particularly within community settings, and collaborating with our voluntary sector colleagues with a particular focus on not only engagement, but also the assessment and management of patients through the pathway. In this, we kind of hope to address improving access for difficult to reach cohorts of patients, which was a major priority and highlighted as a challenge in some of the recent work that the PCN have undertaken. Focusing on what we could control as a PCN and establishing a community-based model to improve CVD outcomes, to engage those that may be kind of underserved. Utilising an MDT in the model that has the potential to free up or redistribute capacity in the form of GP appointments for more appropriate or maybe more complex cases that need to be seen. A big part of this was utilising the already existing kind of R's roles, particularly the health and wellbeing coaches within the community that are able to have longer patient-centered conversations around the kind of ABCs of CBD. But also it starts to address some of the wider aspects of health literacy and also look at some of the modifiable risk factors such as smoking, obesity that are usually addressed maybe further down the line. The ambition of this would potentially allow patients to have more understanding maybe early on in their diagnosis and therefore potentially hopefully need less touch points in the future. Next slide, please. Thank you. The impacts of our new model of care. So again, with a particular focus on improving patient outcomes through the potential to reduce MIs and strokes, and over the kind of 3 years, looking at a saving around to the kind of wider NHS around about £100,000, with a societal return on investment of around about sort of £200,000. With a lot of our workforce already paid for through the R's funding, the only additional cost is the additional GP time in the MDT. But when we factor this against the freed up GP time and the potential income from the NHS Health Checks and the QOF incentives, the overall benefit to the PCN is around about 44,000. The redistribution of well over kind of 1,000 GP appointments, and hopefully our kind of new model of care has a strong emphasis on bringing roles together and developing that skills and knowledge of the workforce involved in cardiovascular disease.
Thank you very much, everybody. I would just like to say a huge thank you for everything that you guys have done and continue to do in Living Well 1. I got to the end of Living Well 1 in November and I was going through massive withdrawal symptoms that I wasn't having our weekly site meetings. And then we had the good news that we would be working together again going into Living Well 2 in 2024. So I have the pleasure of your company and you have the pleasure of mine, hopefully, for a bit longer. So I'd just like to start, as the title of the slide says, is thinking about your personal reflections of the journey of Living Well 1. What are some of your kind of key takeaways from Living Well 1? And I'll go in reverse order just to mix things up. So Scott, I'll come to you.
I think for me, kind of reinforced the importance of the kind of considering both kind of qualitative and quantitative insights, I suppose, perspectives. I think in my role, I think I sit across the kind of voluntary sector. I also sit across primary care. So I think ultimately the voluntary sector is really, really rich on qualitative insight, and largely within primary care, we make decisions from the kind of data that we've got available to us. So I think for me, looking at both perspectives has been a really big eye-opener and something I'll definitely sort of take forward.
Lovely. And Emily?
I just loved it. I loved the whole project. I found it to be a really enjoyable experience. I was able to apply the on-the-job learning to current work that we're doing in the PCN as well. And it was allowed the freedom. I really enjoyed when we were doing our big picture stuff. Think as crazy as you like. So that was my element there. But it was really nice to have that the confidence of the PCN to allow you to think big picture, make those changes. Also found that because our PCN works so cohesively already, it was a really positive and important enabler for us to be able to run with 4 models of care. 4 models of care.
Yes.
So yeah, I just found it really good. Thank you.
All right. And Gemma, I'll come to you.
I'm trying to think if I've got anything to add to what everybody said. I loved it, like Emily and Scott said. I really enjoyed it. For me as a clinician, it gave me the headspace. I spend most of my days thinking, oh, this could be done so much better. And actually the opportunity to sort of step away and not have the pressure of appointments and opportunity to think about it in a really methodical way, I think is excellent, so that when we do propose things and say this is what we suggest, there's such a wealth of evidence behind it as to why. It reminds me of those, you said we did type things. That's exactly what it feels like. We've had that opportunity. And I do talk a lot, but I've loved getting to speak to so many different people. It's just been amazing to have that. Feels like a luxury to have a conversation and really get other people's thoughts on what things happen. And a lot of those really poignant statements that we included in that came from people who were in general practice, like community pharmacists, etc. And it was just eye-opening, made me feel quite humble, really. And I sort of live in a little isolated bubble of general practice. So yeah, really good. Enjoyed it all.
Thank you. I mean, I'd love to just say, okay, done, let's leave it there. But I think we probably need to have a little chat about, were there any challenges that, you faced within the process, and potentially how you kind of overcame them or worked around them. And I'm going to really mix things up now, and I'll come to Emily.
Thanks. So for me, I joined the programme 6 weeks in, so it was a bit of a late starter. The initial non-clinical associate left the business, so I was kind of thrown in there a little bit. So for me, that was a struggle. I found it hard to balance catching up with the work that had been done because the clinical engagement was so important. So having to go back through all those interviews, all that rich data, whilst trying to move into the data interrogation phase, that was quite a challenge at first, but I was really well supported by the Clear team, and it was kind of all hands on deck for a short while just to help catch us up because we'd been one member of staff down. But yeah, it was, it all came with positive, so it was fine in the end.
And Scott?
I think it's a big one, and it's a thing that's kind of been always mentioned, which is, I suppose, time is a kind of it's a massively kind of precious commodity, not necessarily just within primary care, but across everywhere at the moment, across health, I suppose. I suppose even just finding time to kind of conduct the work and get people to sit down and actually have a conversation with us, which was quite challenging. However, I think we did do a really good job of reaching parts of the workforce that probably don't often get a voice. I think we managed to overcome that with quite a lot of well-established links within the kind of PCN, so we kind of managed to overcome that and move that work quite forward. But I think time is always something that gets mentioned all the time, pretty much.
Absolutely. I think that's something that we all experience as clinicians, isn't it? You just kind of get completely focused in terms of what needs to be done right now, and you're thinking about all these changes that you could potentially make improvements on, but you never quite get that headspace. And Gemma, for you, what were your challenges coming into this?
I think there was a couple of hiccups around data extraction, but actually I think that just reflected the complexity of data in primary care, and that we're rubbish as clinicians at coding things, and it certainly made me change my clinical practice, code a lot more now so people can see what I've been doing. And I think like Scott said, because I don't work in East PCN, sometimes it was quite tricky to get confirmation on things. I couldn't just knock on somebody's door and say, does this seem okay? And so I think that being slightly removed had its challenges. But like Emily said, I think they were easily overcome. We got through it, and it didn't tarnish the feel of it or the project at the end, I don't think.
So one of the, I guess, the clear outputs is to kind of build capability within the clinicians that we work with to take forward their learnings and maybe apply this for future projects in different areas. I mean, how would you feel about taking some of the elements of the CLEAR program and applying that to future work? And I guess that's quite a broad question. And Scott, I don't think we've started with you first yet, so we're going to start with you. Or did I do that last time?
I can go. It's fine.
Go for it.
I'm happy to. Yeah, I think for me, I think in being involved in different kind of programs and projects like this before, I think I'm really interested in getting to what are we actually physically going to do. And I think sometimes when you're involved in programs like this before, like previously, they lack a kind of clear structure, which I think clear structure. There's clearly structure with clear. So I think having that structure really helped, and having those kind of well defined, right, you've got this time to do this work, try and get it done, and there's a kind of defined start date and end date, which means at the end you've got some tangible actions to go away with. Whereas I think sometimes being involved in other things, I get lots of frustration, I suppose, around actually what are we going to do. Lots of good discussions, lots of good discussions with lots of numerous stakeholders, but they often lack a kind of a clear structure, which I think this has helped, and I think we'll definitely take it forward in terms of the work that I'm involved in now. I think when we got asked at the end about kind of what we learned, I didn't really know what I'd learned until I'd actually started those conversations afterwards and got actually looking at it from this perspective. I think has really helped and will inform my work moving forward and as an organisation that I work for as well.
Thank you. Gemma, I'll put you back on the spot.
Loads. I'm coding better, for one. I think really subtle things. So I think exactly like Scott says, I think that methodology, knowing that method is brilliant. And I'm so desperate to make changes in other areas now because there's a clear way of doing it. But I think it's really subtle things. You know, one of the clinical engagements, some of the training we did was around sort of challenging your assumptions. So you might think you know what someone's saying from what they've said, but actually, do you? And it sounds really silly, but very, very subtle things like that have impact everywhere. I think I probably communicate better with my husband than I used to do, which is completely irrelevant, isn't it? But I'm more willing to listen. So I think loads. I think it has a huge impact, and I think there's definitely massive amounts of skill. And like Scott said, I'm probably not aware of how I've changed, but it'd be quite interesting to like rewind time and see what I was like at the beginning. But yeah, in terms of the confidence as well, I think to make change, but to get the evidence behind it, I think it's been fantastic, definitely.
I'd love to see how you would code that stakeholder interview with your husband and what your key themes were that came out of that.
I don't think you would. It's more about emptying the dishwasher and things like that, and not assuming that.
We need some workforce, some extra resource here. Bring in the kids. And Emily, for yourself, if someone said to you, well, now we want you to look at dementia, for example, do you think that you would know where to start? I guess that's a hard question for you.
Yes, but I think, like the other guys said, it was hard when on the last session that we had when we had our face-to-face, and they said, "So what have you learned?" And I was like, "Oh, I don't know. I don't have it." You know, when you it takes a minute, and when you step back, you're like, "Oh my God, I've learned so much." But we have we're doing loads of projects within our PCN. So I'm now training 2 of my colleagues using the skills that I've learned in Clear and really engaging them, helping them to take these projects forwards, and also myself trying to take a step back because I'm a bit of a control freak. So it's been massively valuable within our PCN already. We've won a bid for the obesity work, so we've used those skills to write a funding bid to then project plan it and carry on learning now. So yes, I think this won't be the end of us, and now I change programs.
I think I'll probably draw our reflections kind of phase to a close and just briefly talk about Living Well 2024. So if the comms team don't mind bringing that slide up for me. So we've hinted at this a little bit as we've gone through this webinar. So Living Well 1 is come to a close, and now we are moving into Living Well 2 with the sites. The 3 sites that we have been working with. But not only do we have the Living Well implementation, we also have something called Clear Focus Living Well, which is to support an additional 14 PCNs. And the aim is to get 2 in each region to think about their own CVD pathways and to think about the wonderful models that the 3 sites have been working hard on, as well as the proof of concept model, to see which one of those would they could take and adopt to their own pathways, and build their own kind of workforce and to understand what that would mean for them. So that's currently underway as part of Living Well 2, and so we've got the first phase underway, but there is phase 2, and John will talk to you a little bit more about an opportunity for anyone on the call who may be listening. And we also have a toolkit that has been developed where potential PCNs or practices who want to consider their CVD pathways can take a method with some learning from the Living Well implementation and the focus, and work through their CVD pathways in their own time with their PCN. So that is coming soon, hopefully delivered by the end of August 2024. So some exciting stuff that's come out of the very, very hard work from everyone that's been involved in Living Well 1 and now Living Well 2. So I'll hand back over to John.
Thanks so much, Nat, and thank you to all three of you for your wonderful insight into your experience and your journey so far with Living Well 2023. For me, watching on, especially as a local lad very close to Scott's PCN in particular, it's so refreshing and inspirational to know what's going on within this programme that I am now a part of myself as the comms team. You should be very, very proud of yourselves, and I'm so glad that the Clear programme has clearly benefited you a great deal, and will continue to do so in the future. With regards to the Clear Focus Living Well webinar that we've got coming up soon, I'll touch upon that a little bit later towards the end of the session. But for now, I'd like to open the floor to any questions from our audience, either with a polite emoji hand up, or if you want to go old school through the chat, that would be wonderful. So let's see the room if we can, Emma. Any questions, please? We've been that informative in 48 minutes.
I was going to say, we've been
questions.
that thorough. There are no questions.
I think perhaps everyone's still just in awe of the presentation, quite honestly. Do we have any questions in the chat? Orlando Hampton, thanks so much. Would you like to go ahead and introduce yourself, and who's your question for?
Hello, Orlando Hampton. I'm head of something in NHS England. My question was for whoever mentioned alternative roles in primary care, and I think it might have been you, Scott. And I was interested in that you said, well, that was taken care of, but of course that's a whole change to primary care in itself. So it was about your view on the how those two change programs could complement each other in now and also in the future as they grow into themselves, if that makes sense.
I think so.
Was it you that said that?
Possibly. I don't know
not,
what
I've
I
just
said.
thrown you under the bridge.
Reference to the kind of the additional roles you meant, Orlando.
Yeah. So what I think you said was, and the additional roles took care of that. So you didn't need to worry about in the context of the change you were responsible for. But you could think about it in the context of anything, couldn't you? Because it's an enormous, mesh of variables, and you're trying to deliver your change in your place, in your way. Whether how and where other policies had complemented that or competed with it, and how you saw that going in the future.
Well, I think in specific context to the kind of what I'd mentioned, or what I can remember I mentioned, it was around kind of the R's roles, and I suppose I think in our particular PCN, we've utilised the kind of R's roles, not necessarily just the clinical roles, but also the non-clinical roles in lots of different ways in order to kind of achieve the ambitions of the kind of PCN. So I suppose it's utilised, and I think particularly the non-clinical workforce, they possibly underutilised, I think, in a lot of areas, and I think a lot of areas have roles and have recruited roles, but actually they're not really well linked into long-term condition management, and I think they should be. I don't know whether I've answered your particular question there at all in any way, shape or form, but
well, you have in a tangent, and I noticed Gemma was nodding. So Gemma, you're definitely going to have to say something, because you also said you like talking. But what I took from that was that you were saying that the R's roles embedment is far from finished, and we've far from finished capturing the opportunities there.
I don't think we've exhausted that in any way, shape or form. I think we're still very much at the starting point. I think there's definitely a lot more structure to support those roles, but I don't think we are anywhere at a stage where I think even in our local landscape, PCNs recruit differing roles, and actually you're utilising them for so many different things that actually there's no sort of consistency in their approaches and the work that they're involved in.
Yeah. So I'm hearing opportunity for the next phase of their policy and your delivery. Claire's nodding. She's going to have to write it up.
I've just put my hand up just to come in as well, just to say we've done a few different projects in primary care now, and I think the utilisation of ARS roles just is so variable across PCNs. You know, some PCNs are employ at a PCN level. We have others that divvy up the money and employ at a practice level. So again, you've got that push-pull between, are you doing a PCN hub model or are you doing it at a practice level, which again can lead itself to kind of inequity potentially and kind of access to services and care. So I think that's maybe something that again needs thought. But I think the other thing that we've seen come through is again where sometimes PCNs have gone out because the funding is there, but without necessarily planning what that workforce is actually going to be utilised for. So again, I think the real benefit of this project has been actually a really well thought out kind of, this is what we want these roles to do, and this is what the impact and the real benefit could be from that. And again, I think sometimes what we've seen and what we've heard when we've been doing engagement is that if there isn't that clear plan, it's often very much down to the individual who's employed in that ARS role, how much they kind of make of it, how confident they are to kind of create their job role if they don't have that kind of clear structure and support around them. So that's my kind of learnings, I think, from some of the projects that we've done in other areas as well as this Living Well one.
Thanks, Claire. Did you want to add anything to that, Gemma? I know you were nodding furiously.
Yeah, I think you're right. I think that was one of the big things of ours, was looking at skills. So actually, I think a job title, I think sometimes that restricts people. Actually, it's what's your skill set and what are you best, what can you do and what can you do well. And I think there are certain skills that I have as a GP, and then there are jobs that I do that I think actually this isn't a very good use of my skill set. Actually, there are other professionals out there who could do that. And I think what Scott talks about, I always go back to GP admin time. A huge amount of my day is doing admin. I never became a doctor to sit and do admin. I became a doctor to meet people and to interact with people. So there's huge components of my work that could be done far better by other people. And I think exactly as Claire said, I think that's been my frustration with the ARS role. People have thought, oh, there's money, let's get the money. And then it's not worked. And actually, it's not because it's the ARS role that's not worked. It's because there hasn't been that thought beforehand about what do we want them to deliver and how can we do this. And I think the areas that it has worked exceptionally well has been very personality driven sometimes, or a PCN with very clear ideas. And they are in their infancy, aren't they? They're very, very new. I know they've been around a while, but I would still say this is infancy compared to other jobs that have been around in the NHS. And so I think there is huge potential that's untapped there. And I quite like, I love thinking of things as skills based rather than a job title, because actually, you know, don't come and see me with your knee. Come and see me with something else, but don't come and see me with your knee. I'll do an all right job, but another GP will do a much better job. I'm still a GP, there's still a skill set there. See one of our physios, you'll get a fantastic service. You're far better seeing one of our physios than you are seeing me. It's a very clinical example, but yeah, I think there's huge opportunities. And I think, unfortunately, because of the workforce crisis, and I can only speak from a general practice point of view, is none of our trainees want to do general practice. They look at me doing 12.5-hour days and think, no thanks, I'm going to go and work in the hospital. So we need to think differently. We need to think, how can we not lose the quality of general practice? How can we enhance it, and how can we do things in a different way?
Yeah, and a final thought from you, Emily, on this one?
I am an ARS role as a care coordinator. I have stepped up massively from my lowly bottom of the earth pile to be involved in and be the non-clinical associate and then run forwards. But within our PCN, I think we've got nearly 60 ARS role members of staff employed. So there has been like a clear structure and plan, and we'd really try and work cohesively, engage the staff, use them, like Gemma was saying, like skills-based competency. So other care coordinators have been trained up, they can take blood so we can vaccinate. We work within a skill set of these people and really wrap around general practice, trying to relieve that burden. So the GPs are doing what they need to do and see the acute cases, not the things they don't need to be seeing. But yeah, I think ours roles are really important, and obviously we don't know what the long-term plan is, but there's a massive place for them within general practice to support and increase our offerings.
Thank you so much for that, everybody. And Orlando, thank you very much for starting off that conversation. That was a great one. I'm just going to move quickly to the chat. Olusola, thank you very much for your little comment there. Very insightful session, really inspiring too. You are more than welcome to tell us how inspiring you found it, or the reason why you found it inspiring, but I'm not putting you on the spot for now, but if you'd like to say so, it'd be lovely to hear from you.
I think for me it's quite varied. Hearing from different people, and one thing I also like the way the presentation came through, having the same pattern from different projects, though different results coming through. And then I like really very much appreciate the fact that the clinicians love to have their time back, and whatever anyone is doing to make it happen is a great thing. That's inspiring, and lots of learning. I think I need to read through the slides. I've actually snapped them, but then if we can get the slides, that would be good. Thank you.
Thank you so much for that comment. We are going to be sharing the recording next week. I will speak to the presenters first with regards to sharing the slides, because that wasn't our initial intention, but we've had a couple of requests for that. So perhaps we could send them over in a revised PDF form for you. But I will get back to you certainly. And I know Sarah requested them as well, but keep an eye out for the recording. I am going to stop any questions here now with just a couple of minutes to go, because I've got a couple of other slides to talk you through. If anybody has any questions that they weren't able to raise right now, by all means, email me directly at the info@clearprogram.org.uk email address, and I will pass them on to our presenters for you. But for now, can I just take this opportunity again to thank everybody who's joined us, not only our presenters and to Nat and Claire for supporting, but to everybody else who has joined us online today. So thank you for that.